Thank you for the invitation to be here. It's a great privilege. Do I just hit down and it starts? Yeah. So Roger asked me, he invited me to give this talk in December of last year. And I said, oh look, it's a great invitation, thank you very much. I'm just not really sure I'm the right person or the right fit for this talk. And he said, no problem, I'll talk to you. Can I give you a call? And I'd say it was 5 o'clock on the 22nd of December. I would have said yes to anything at that point for the Christmas holidays to start. So I remember having the conversation saying, okay, that would be fantastic. But you know, when you get pushed way outside your comfort zone, which is what happened when I was preparing this talk, it does give you a chance to reflect on, take time to just spend, like Tracy's just done, thinking back through what was my experience of evidence-based practice and what was it in the context of my professional career. So I too have to, I'm going to try and use this. I have to give you my biases right away because there's plenty of them. My PhD was all about outcome measurement in physiotherapy and the changes that had occurred in practice over a period of time that I was doing my PhD. The piece at the top is the very first piece that I ever wrote in a physiotherapy publication, and that was in 1996. So, you know, I guess Tracy and I came from a very similar stable, which was a very quantitative, this is the way we need to be shaping the profession, let's measure it, and if we can't measure it, then is there a value on it? I think certainly over my career, I've come to live with nuance and ambiguity far more comfortably, and I guess that's just because you live a life, right? I was very definitely a quantitative researcher, absolutely no question about it. Randomized controlled trial, the only way to do it. But we did a wonderful piece of work looking at involving family members in the delivery of exercise for people with stroke. And it came from a clinical experience that I had had with a patient of mine who really needed extra exercise, and the only person who could give it to her was her helper at home. So anyway, this randomized controlled trial was published in 2011, but we also did a nested qualitative study in it. Now, let me tell you, we got the randomized controlled trial published in 2011, and it took us another 3 years to get the qualitative research published. But that opened my eyes to the power of understanding and capturing the experience of the participants in this research. And what was really interesting was this study was about, we asked family members to deliver 30 minutes of exercise 7 days a week for 8 weeks with their loved one who'd had a stroke. And family was in its loosest sense. It was someone who was willing to do this for this person. And we were prevailed upon to measure carer stress because a peer reviewer of the grant application had said, you're going to stress these people out of their minds getting them to do this. So we measured carer stress using the Carer Strain Index. And what we found in the randomized controlled trial was that actually the family members who delivered the exercise intervention reported less carer stress than the family members who didn't. Now, that was fine. That was a great result in the randomized controlled trial, but we would never have been able to unpack it if we hadn't done the interviews. And then what we understood was one of the aspects, and we can't link it, you know, but what was really, really powerful in those stories, in those interviews, was empowerment. A bad thing happened in my life. I felt powerless. When someone asked me to give these exercises, I was given back some control. No randomized control trial is going to give you that. And to me, this was an enormous part of my learning journey, and you can see it's quite recent. The other bias I have is that I was the chair of the board of a fabulous charity for people with Parkinson's disease, and my friend who founded the organisation once gave me a fantastic quote, which was, she said, you know, it was about the expert patient, and she said, you know, I see health professionals for about 60 hours, if I'm lucky in a year. Think about all the other hours that I live with this disease, and then tell me who knows most about it. And that was just a powerful, and it's stayed with me. And then my final, I guess, bias. Killian, are you here yet?
Yeah.
Yes, there he is, great. I work with Killian Condon, and this is some research that Killian has undertaken. And it's really starting to unpack what does the lived experience of evidence-based practice and evidence-based decision-making mean for physiotherapists. This was a scoping review, but Cillian has also completed some really fascinating interviews about what do people actually do on a day-to-day basis to practice this. So there'll be more to follow. But that's where I'm coming from, I guess, in terms of the personal journey that I've had, and you bring that with you when you craft your stories. And I'm standing here as the president of WCPT, but I have to tell you that these are personal musings, so please don't tweet the president of WCPT says in a way that suggests that it's a truth and an absolute truth, because it's not. It's my personal experience. For those of you who don't know what WCPT is, we are the World Physiotherapy Organisation. We have 111 member organisations. We represent over 350,000 physiotherapists around the world. I'd like that number to be bigger. No pressure, but we would. And we are bonded by common aims and goals. So I spent quite a bit of time thinking about this, and there are no references on this slide, but here's my view. Evidence-based practice, what in the world should it be? Centred, clearly around the person at the centre of this interaction, this engagement, this relationship. Contextual, connected, creative, and curious. And I don't think I could have said that 20 years ago when I started my journey as a researcher and as a clinician. To me, that's about living with the differences, the changes, the ambiguities, the lack of understanding, I guess, what we don't know. And today is wonderful in terms of whether I'll be changing that at the end of the day, and I'm looking forward to that. Here's 3 lots of evidence I've been asked for recently, or we've been asked for at WCPT. We've been asked to provide evidence in support of physiotherapists being able to use manipulation in their practice to a physiotherapy organisation that was trying to prevent a law being passed in their national parliament that would restrict the use of manipulation in PT practice to doctors and chiropractors. And this isn't a small country in the middle of nowhere where you'd be kind of questioning the standards of physiotherapy. This is a well-established, physiotherapy profession. We were asked at a WHO meeting to provide evidence for the economic impact of investment in physiotherapy and health professionals. In other words, why should we be spending money on investment in health and human resources? It was a curious question to have to answer. And then we are constantly asked to provide evidence in support of direct access and advanced scope of practice. But I was asked a question quite recently, which was, well, are there any randomised controlled trials that look at the difference between a bachelor's degree for pre-registration education for physiotherapists and a DPT? And I really was speechless, because I was thinking, well, A, no, there aren't, but B, why would that even be a relevant study? How would you do it? And it was this was in the office of a minister for education. So this wasn't a slouch. This was a key policymaker. I was like, okay, well, let's just think of another way of answering that question, because the answer is no. So in contextualising what should evidence-based practice look like, if you like, in the global context, I want to talk through some of the interesting answers that we've received in polls that we've been doing on consultation about looking forward in physiotherapy for WCPT. And I guess what really interested me in this particular consultation process was that we had 3,700 responses to a series of polls from physiotherapists all around the world. So this was a really wide engagement process. And we asked physiotherapists about the opportunities for physiotherapy. So these were, the top 5 were direct access, research evidence in relation to the benefits of physiotherapy, the role of PT in ageing populations, collaborative practice, and our role in community, in delivery of services in the community. So physiotherapists are practicing in these contexts they perceive as opportunities. So every day, physiotherapists are engaging with their patients and their clients, and they see these as being the opportunities. These are the contexts within which they deliver or engage in evidence-based practice. These are the challenges. So pay and working conditions. Top 5. It's funny, I asked physiotherapists in Iran last week, were these the challenges that they faced? And, you know, there was a lot of nodding in the audience. So they may not rank as highly in your experience, but it's interesting that, you know, they are there. So these are the challenges. Again, lack of esteem. That's not somebody telling me I'm doing a good job. That's actually lack of professional esteem, lack of professional recognition for the role that we can play in really changing people's lives and empowering them to live the best version of their lives. Improving the understanding of physiotherapy and getting other stakeholders to understand what it is that we can deliver. A lack of autonomy, not a challenge probably in the United Kingdom, but very powerful physical medicine doctors in many parts of the world still can hand out a prescription to physiotherapists and say, this is what I want you to do. Tell me how that's evidence-based practice. You know, clearly it's not. And then encroachment. And I think we have to be careful about encroachment because we're encroaching on other people's roles and they're encroaching on ours. But it is about understanding these are the challenges within the context that we work in. So then we asked them what the priorities within WCPT were. And actually, interestingly, promoting physiotherapy contribution in support of what we do. Direct access, again, not a challenge in the United Kingdom, in many parts of the UK, still a challenge for many places around the world. Influencing decision makers, professional autonomy, and paying working conditions. So this was our strategic plan, and this is, if you like, the context in which I situated how do we look at what evidence-based practice is within this context. And so we want to be a global community of physiotherapists where everyone feels connected. A community that has global influence and brings about changes to health policy and practice. A global community that promotes the unique role and values of physiotherapy. An organisation that shares knowledge and an organisation that's fit for purpose. And really in the 1, 2, 3, 4, you can see that situated within that, we have to start providing the evidence in support of what it is that we do. Evidence can situate very nicely in there. What that evidence is probably going to change and evolve and grow. But let me just give you some ideas of what I thought situated within these. So global community of physiotherapists, where everyone feels connected. Well, WCPT really works to bring together communities of knowledge. And certainly from some of the interviews that Killian has done with the physiotherapists, when we ask them about how do you access the information that you bring to your decision making, a lot of it is around connecting with communities of knowledge. So in other words, I connect with someone within my PT department or the clinical interest group that I'm part of or the network that I'm involved in to see what's the solution to this complex perhaps question that I'm confronted with. So we really promote communities of knowledge, and certainly if you look at how those connections are made so much easier now, looking at global physiotherapy and looking at evidence-informed practice, the ways that we can do it and the connections that we make are far more organic and far more easily done with social media particularly. A community that has global influence and brings about changes to health policy and practice. Well, we're not going to change health policy unless we can actually demonstrate some effectiveness in that. And health policy then trickles down to the context in which we work, the reimbursement that we receive for our services. If you're in a health system model, the commissioning decisions that are made around what's effective and what's not effective. And certainly from a global perspective, WCPT really draws on expert physiotherapists around the world to contribute to the global debate. So recently we were involved in a WHO meeting where we tried to emphasise the contribution that physical therapists can make in non-communicable diseases. So again, very much trying to draw on our international expertise network to contribute to WHO policy. And that's where I guess one of the areas that a global organisation has to really excel in is actually at that influential level, at WHO, or empowering and working with member organisations to influence nationally. And that's where we need to be able to tap into the evidence and the expertise and bring it to those conversations. This is an enormously important report that Catherine co-authored with Pete Skelton. And again, you know, for a lot of us sitting in this room, we've never been confronted with the impact of an earthquake or a natural disaster or a humanitarian disaster. But we will be confronted with it in some ways, the consequences of it, because people will come to our communities from other parts of the world having experienced those significant changes and challenges in their life as refugees or as displaced persons. So in a way, that global conversation, understanding the challenges that people face in the aftermath of those and how we manage them in our communities is going to be different. But this is a different report because this report draws on the evidence and the experiences of physiotherapists in the front line in disaster management, but more importantly, that they are the rehabilitation professionals that need to be there afterwards. And Catherine is over there, so you can, if you want more information about that, have a chat to Catherine. And then Tracy and I have done some research on understanding the impact of the direct access. So the evidence around direct access and why it's important. And look, the UK, Scotland, England, and now more recently Northern Ireland have led the way. Your research is quoted liberally in terms of informing policy in other parts of the world on the impact of direct access and how that empowers people who wish to self-refer to physiotherapists to be able to do that, and how that has cost savings for the system. A global community that promotes the unique role and value of physical therapy, and of course Tracy talked about this, but I talk about this series of work around the world, and this is a really, really valuable resource that has been produced by the Chartered Society of Physiotherapy, and if I get a chance to talk about it anywhere, I do, because it is fabulous. And not only is it fabulous, but it is also freely available to anyone who wants to tap into it, and that is an enormous gift to physiotherapists around the world, because, you know, if you live in Malawi, there's one physiotherapist per million of the population. How do you practice evidence-based practice in that context? You know, so, and in other parts of the world, you know, the profession is only developing. So where do you tap into these resources? And yes, this evidence is situated from a cost perspective in the UK, but it's still a compelling story to be able to bring this and say, if we were to map this onto some of the costs in our country, what would that look like? Now, obviously, culturally, we need to be able to, and Malawi is probably not the best example, but there are other parts of the world where, you know, the profession is developing, and these are really relevant resources. So they're a fabulous resource, and thank you to the CSP for their generosity in allowing all of us around the world to tap into them. The Canadian Physiotherapy Association also has some fabulous information, and interestingly, I had a chance to speak in Stormont at the inaugural Chartered Society of Northern Ireland, the Northern Ireland branch lecture in December this year, and I just used some of the highlight figures from Physiotherapy Works and some of the value physiotherapy information. And you know, when you put those highlight figures up there, the MLAs were writing the information down. That's where you manage to bring the evidence into influencing key decision makers. So that's out there as well, and it's a wonderful way of sharing information. I just want to talk about one other context from a global perspective, because I think as we move forward, we are, I guess, going to have to sort of manage the personalised, the increasing information from a science perspective around personalised medicine, if you like, but personalised physiotherapy. In other words, what do we know about this person and their context, but also their genetics and their physiology and their metabolism around perhaps prescribing some sort of exercise intervention. So we're going to have a lot of basic science that will inform some of the interesting information about being able to perhaps respond to exercise. And then we're going to have to start looking at some of the environmental information. And I just wanted to share this project with you because I like this project. Now, in the interest of full disclosure, I live with the person who's involved with this project all the time, so I hear a lot about it. But my partner is the head of the Steno Diabetes Centre. But this is a really interesting project because this is a project that's looking at cities and urban diabetes and the impact of cities and the place that you live in and how that impacts on your health. So that's evidence-based practice in a whole kind of different space. And I just want to share one result with you, and these results are all out in the public domain, so I'm not sharing something. But this is a model about understanding vulnerability, and it comes back to some of the concepts you were talking about, Roger, as well. This idea of what is it within that bigger picture that contributes to that interaction. So we know we're doing one thing. We know that perhaps we're delivering an intervention. But if we, and in many ways, we have been focused in the biomedical factors. But this model has been developed as part of the Cities Changing Diabetes project, and it's about understanding vulnerability. So understanding the vulnerability of someone to develop a change in their health for the good or for not so good. And obviously the social factors are something that we've considered, and the cultural determinants are very important. But this is a map of Copenhagen. And in what the Centre for, I think it's probably the researchers at the Centre for Global Health at Copenhagen University have discovered is, I'm not going to try this, but in the inner city, the percentage of individuals at high risk of developing type 2 diabetes is 12%. But Copenhagen is a small city. In those two red regions in Copenhagen, the percentage of individuals at high risk of developing type 2 diabetes increases by 6% in one region, and that's 7 kilometres. And that's the kind of evidence we're going to have to start incorporating into some of our practices. In other words, what is it about where I live, what is it about the aspects of where I live that contribute to my high risk of developing something, or my risk of not recovering as quickly. So those are the really interesting, if you like, global contexts that we're going to have to start looking at. And you know, the research is being done in that area, so we are going to have research delivered in different ways. And I just found that fascinating. In the space of 5 kilometres, it goes from 12% to 15%. So there's a lot of really interesting information that's going to develop from, you know, some of these kind of big projects that we're going to have to bring in, as well as the personalised basic science research that's going to have to be incorporated into our decision making as well. This is another really interesting feature, and again, as I say, full disclosure, I live with a person who lives with this every day, so I know a lot about it. But this is where really patient empowerment is taken to the full, if you like, consequence of it, which is that the person attending Stina with diabetes is able to check in, book their appointments, decide when they return, put in their list of things, their agenda for the conversation that they want to have with the health professional that they're visiting, complete control over their journey through the healthcare system in a way that I've never seen before. And that is just remarkable, because the text that you get, I really want to talk to you about this. I'm a little bit uncomfortable raising this. So there's a checklist of things that I want to talk about, things that I'd like you to raise with me, and then free text for whatever. And of course what's interesting is this free text then is being available to be analysed, to have a look at what are the things that people are raising, how can we consider these? So, I'm coming to the end. My experience of, I suppose, global physiotherapy is that we still have to hold on to, at the centre of this, the human being that we are engaging with. But recognising that we're human beings too, and that we bring all our little biases and our little life lived to the interaction, and that we can't park that either. And how do we factor that into the relationship? It's contextual, and the context are going to be changing, and the information that we find out about the context is going to be remarkable. Like that Cities Changing Diabetes project is remarkable in terms of telling us more about context, and there will be other fabulous projects like that out there. I have no doubt about that. Connected. Interestingly, some of the research around professional competence shows that if you are engaged and connected, you are far more likely to be professionally competent. If you're disconnected from your profession or not engaged in the regulatory space, you're more likely to be perhaps crossing over those boundaries that raise red flags with regulators. So connected, and it's easy to be connected now. I mean, really, we are so privileged. In Iran last week, when I was visiting there, there's no Twitter, there's no Facebook. So when I was talking about communities of knowledge on Facebook, I suddenly realised, well, okay, that's fine, talking about it in Ireland and in England, but not so much in Iran. Creative. We are a really creative group of people, and I think evidence-based practice is going to be, this is a creative space that we're in today, and giving ourselves the opportunities and the permission to explore beyond the boundaries now, because as Tracy said, we're in that space, we've ticked that box. Now let's be curious about how we can take a lead in perhaps looking at this differently. Of course, I couldn't not suggest to you that all of those aspects that I've just talked about, curiosity, creativity, connectedness, there's a fabulous opportunity for us to take this conversation forward in Cape Town in 2017. And I really think, we could, if there's really interesting things that we want to take forward and start exploring from a more culturally diverse perspective, let's think about a networking breakfast that we could do that there and start to really explore these beyond this space. And the reason why the animals are on the table. is because me, Tracy and Catherine are demented carrying the animals around. You have to have your photographs taken with us, with these animals, and then you need to tweet them with those hashtags. So Tracy sent me a message yesterday saying, are you bringing the elephant? I said, well, it's the sneakers of the elephant. And then I contacted the hotel and they said, well, we don't have a gym, but you can go. I thought, okay, the elephant makes it to the cut. So these two have your, and this one here, Catherine has one also. Remind me what that one is again.
Sorry?
What one is that again?
He's a Cape Buffalo.
A Cape Buffalo. She's a Cape Buffalo.
Most of the others are male.
So I want to thank Twitter. Because I would not have had the privilege of being here if I hadn't connected with Roger on Twitter and then sent him, I managed to see one of his very complicated papers, which I really commend to you on Scientific Truth, which I have used all over the world. So then I had to say to him, okay, is this actually what you mean in this paper? Because I've read it and I'm not completely sure I understand it, but here's what I think it is. And he said to me, that's fine, you've got it right. And then what happened was, the announcement of this project came at a time when I was 3 days before I was giving a talk in Norway. And I just thought, okay, this is too good to be true. We are celebrating this project in terms of me being able to tell the Norwegian physiotherapy community about this wonderful project. So then we connected on Skype and we finally exchanged our first kiss at the bottom of an elevator. The Chartered Society of Physiotherapy, as Tracy said, I was like, do we shake hands? So anyway, thank you Twitter for connecting me with Roger. Thank you, more importantly, to Paul Tell and the team for this fabulous opportunity to explore some of the thoughts that I have about this and then the privilege of presenting them to you. They are simply my personal thoughts. Take them, leave them, discuss them, walk away from them as you wish. They are what they are. Thank you.
Hello Emma, we've just had a great chat from you with the regarding evidence-based medicine. You mentioned about being connected being very, very important for clinicians. What would you say to any clinicians that aren't on Twitter at the moment, for example?
Well, for me, I would suggest that it's an opportunity lost. But I recognise that people might find it challenging, they may feel that it's not for them. So really the most important thing is to be connected, but social media is now an essential part of our professional practice. And find some form of social media that works for you, whether it's Facebook or Twitter, and don't be concerned about getting started. You can just get started and simply, be quite passive on Twitter for a while before you, kind of get more engaged and get a feel for how you'd like to use it. But for me, it's been an enormous positive. So there's nothing to lose and everything to gain by being on Twitter.
I agree. I think some people find it a little bit intimidating, so I think that point about being passive on Twitter can give you a good idea as to how to start.
Yeah, it's a great way of getting started, and then have a look at people that you trust and that you are professionally engaged with and see how they're using it.
Yeah, brilliant. And what advice would you give to our new grad students? They're obviously being taught about evidence-based medicine, and then we're having conversations today that there are problems with the evidence-based medicine. Is there any advice you'd give to them to help them understand where we're trying to go?
Well, look, evidence-based practice is, as Tracy Berry mentioned, it's not as simple as we probably think it is. And it is a challenge to practice it fully in busy clinics. But I guess my advice is don't be afraid to ask questions if you don't understand something about the science or you don't understand how to access the knowledge. Always, always, always hold the patient in the centre of that engagement, and don't forget that that model of evidence-based or physiotherapy has not just the science and the research, but also the patient and their values and their experiences and their lives and their expectations as part of the triad of information that we use. And also remembering that you probably know more than you think, but also you're surrounded by a community of knowledge, you're surrounded by colleagues. Never be afraid to ask a question, and don't be daunted by it. Don't be afraid of it, but recognise that it is bigger than just simply critically appraising the research.
That's absolutely brilliant. Thank you very much for asking a couple of questions of us, and I'll let you go and enjoy your coffee.
No problem at all. Thank you.
Thank you.